Hello, in this video we are going to talk about herpes simplex infections. See, herpes simplex virus infections, they manifest as common vascular eruptions on the surface of skin and mucosa. Herpes simplex virus infections occur in two forms. First is primary form, that is systemic form, that is resulting from the initial infection or first time infection in an uninfected host. Next form is secondary or localized herpes, that is due to viral reactivation in the previously infected individual. Both the primary and the secondary forms of herpes simplex virus infections are self-limited in individuals with a healthy immune system. But if the immune system is compromised, recurrence of the secondary form are frequent because the virus can remain latent in the ganglionic tissue of the individual. Now the treatment aims to control the symptoms of the herpes rather than the cure of infection. Now a word about etiology and pathogenesis. First is a seronegative individual who has never been exposed to herpes simplex virus before, or those individuals with low levels of protective antibodies to herpes simplex virus are at greater risk of this infection. Physical contact with an infected individual and exposure to body fluids are the typical ways by which herpes simplex virus infection is transmitted. Also, the spread of infection through airborne droplets, contaminated water, or contact with inanimate objects is typically not well documented. Normally, the fusion of the viral membrane with the host cell membrane is facilitated by the sequential binding of viral glycoproteins onto the surface of host cell membrane. This process results in insertion of viral genetic material into the host cell cytoplasm, and due to this there will be the activation of specific genes during the latic phase of infection. These activated genes includes immediate early genes which are represented by IE and E, which code for regulatory proteins and proteins involved in DNA replication. The late genes or L genes are those genes which encode structural proteins. After this, the infection progresses, and during the primary infection, only a small percentage of individuals exhibit clinical signs and symptoms of infectious systemic disease. The majority of the population experiences only subclinical disease, meaning they do not display noticeable symptoms for herpes simplex virus infection. After the primary infection, most individuals become seropositive. That is, their serum will test positive for herpes simplex virus infection, meaning that they will develop antibodies to herpes simplex virus detectable in laboratory tests. Now the laboratory tests can identify a vast majority of individuals who have been affected by this virus. The incubation period after exposure to the virus typically ranges from several days to weeks before the symptoms will appear. A symptomatic primary disease may lead to vasculo-ulcerative eruptions known as gingivostomatitis in the mouth. This eruption occurs in oral and perioral tissues, typically at the original site where the contact with the virus has occurred. Now, after the resolution of primary herpetic gingivostomatitis, the virus is believed to migrate along the periaxonal sheath of the trigeminal nerve to the trigeminal ganglion. It will move from trigeminal nerve to trigeminal ganglion. This mechanism of migration is still unknown. In the trigeminal ganglion, the virus can enter a latent stage or a sequestered state. During latency, the virus remains dormant. That means it will not produce any kind of infection in the host, and no infectious virus particles are produced. Earlier we talked about some genes, okay? So out of those genes, only early genes are expressed, while the late genes, they are not activated. Herpes simplex virus can evade the host immune response by interfering with the presentation of major histocompatibility complex, MHC antigen, class 1 on the cell surface. Due to this interference of major histocompatibility complex antigen, activation of cytotoxic T cells is prevented, which further depresses the immune response. Now, secondary virus reactivation can occur following various triggers. For example, exposure to sunlight, which can cause fever blisters. Other triggers include onset of cold, leading to cold sores, trauma, menstrual cycle, stress, or immunosuppression. Any condition that leads to immunosuppression will have the potential to trigger the reactivation of herpes simplex virus. These triggers can lead to secondary or recurrent infections of herpes simplex virus. Also, an immunocompromised host may develop severe secondary disease. For example, herpes simplex virus seropositive patients being prepared for bone marrow transplants with chemotherapeutic drug conditioning with or without total body radiation are at risk for secondary herpes infection. Now, post-transplant chemotherapy also predisposes seropositive patients to severe recurrent oral infections because the individual's immunity is going down. Individuals who are immunocompromised as a result of HIV may also exhibit significantly worse secondary disease of herpes simplex virus infection. Finally, the seronegative patients who are immunosuppressed in preparation for organ transplantation may be rarely affected with herpetic disease. Means a person who is immunosuppressed but is seronegative patient, that is he or she has not been infected by herpes simplex virus in his whole lifetime, they may rarely be affected by herpetic disease. Now, upon reactivation, the dormant virus in the trigeminal ganglion travels along the trigeminal nerve to initially infected epithelial surface. At this position, the virus replicates, leading to focal vesiculo-ulcerative eruption. It is also believed that nearly all the secondary lesions originate from the reactivated latent virus. Although the reinfection with different strains of same subtype is considered a remote possibility, but the primary source of herpes simplex virus secondary lesions is the reactivated latent virus. Now, there are two types of herpes simplex virus, that is herpes simplex virus type 1 HSV1 and herpes simplex virus type 2 HSV2. Now, herpes simplex virus type 1 typically affects the orofacial region, while the herpes simplex virus type 2 affects the genital region. Although a small percentage may be caused by herpes simplex virus type 2, which is a result of orogenital contact or sexual contact. Next is, clinically we cannot distinguish between the lesions that are caused by herpes simplex virus type 1 and herpes simplex virus type 2. The latent virus in herpes simplex virus type 2 is sequestered into the lumbosacral region. Herpes simplex virus type 1 is sequestered or is remaining dormant in trigeminal ganglion, and type 2 is remaining dormant or is sequestered in the lumbosacral ganglion. This is the difference between the two. Now, if a previous herpes simplex virus type 1 infection has occurred, it may offer some protection against herpes simplex virus type 2 infection due to antibody cross-reactivity. Now, in antibody cross-reactivity, antibodies are generated against one antigen, that is herpes simplex virus type 1. They can also recognize similar strains of virus up to certain extent, and these antibodies can bind to those strains of viruses. For example, if an antibody is produced in the body against herpes simplex virus type 1, it will recognize herpes simplex virus type 2 up to certain extent and will bind to it, providing an additional immune response or a faster immune response to herpes simplex virus type 2 infection. This is because the strains of the viruses, herpes simplex virus type 1, type 2, they have certain antigenic similarities in their protein structure. That is why antibodies cross-react and provide additional immunity or a faster immune response to strains of virus of a member of whose family has infected the host earlier. Now, after all this, a phenomenon known as viral shedding occurs. Viral shedding is a phenomenon in which infected but asymptomatic individual, he or she may be capable of transmitting the virus. Asymptomatic shedding of intact herpes simplex virus particles in saliva occurs in approximately 2 to 10% of healthy adults without clinical symptoms. Now we will talk about clinical features. The primary herpetic gingivostomatitis, it typically affects the children, but the adults who have not encountered herpes simplex virus infection before or who do not have immunity to fight against herpes simplex virus can also be affected. By the age of 15, almost approximately half of the population becomes infected with herpes simplex virus. This infection appears as vesicular eruptions characterized by blister-like lesions that can appear on skin, lip, vermilion border and inside the oral cavity. Now, the lesions in the primary herpetic gingivostomatitis can manifest on any part of the mucosal surface within the mouth. In contrast, the recurrent outbreak of the disease will involve only lips, hard palate and gingiva in the oral cavity. Lesions in the primary herpetic gingivostomatitis are accompanied by several symptoms, including fever, joint pain, which is also known as arthralgia, general discomfort or malaise, loss of appetite or anorexia, headache will be common, and swelling of the lymph nodes is common in the neck, that is known as cervical lymphadenopathy. The primary infection lasts around 7 to 10 days. After 7 to 10 days, the lesions will start to heal, and this usually does so without leaving scars. That means the primary infection healed without leaving scars in maximum cases. During this time, the herpes simplex virus may migrate to the trigeminal ganglion, where it will remain latent or inactive, as we talked earlier. Now, most of the population has antibodies against herpes simplex virus 1 with equal distribution between the genders. For herpes simplex virus type 2, the seropositive rate is higher among women than in men. The secondary herpes infection occurs when the virus reactivates from the latent state of the body, and it's uncommon for seropositive individuals to get reinfected from any outside source. That means the virus is getting reactivated in secondary herpes infection. The reoccurrence is thought to be triggered by breakdown of local immune surveillance. And because of the changes in local inflammatory factors and their breakdown, this allows virus to replicate. Patients typically experience warning signs or prodromal symptoms such as tingling or burning pain in the areas where the lesions will appear. Within hours, multiple delicate vesicles, smaller blisters emerge, which quickly break open and merge into shallow ulcers resembling a map. These map-like ulcers usually heal within 1 to 2 weeks without scarring and rarely become infected. The frequency of the recurrence varies, ranging from once a year to as often as once a month. That means the person will have more recurrent infections with increasing age and decreasing immunity. The secondary lesions usually appear in the same area with each recurrence, commonly on the lips and the surrounding skin. That is referred to as herpes labialis, while intraoral recurrence are typically limited to hard palate or gingiva. Next we have is herpetic whitlow. Herpetic whitlow can occur as either primary infection or secondary infection involving the fingers. It typically arises as a complication of primary herpes or genital herpes, where the virus is introduced into the skin through a break in integrity of the skin. Usually we have little splinters over the skin of the fingers. This break in the skin integrity allows the herpes simplex virus to enter the skin of the fingers and cause the infection in the fingers. Herpetic whitlow can be transmitted through the contact with the infected oral or genital secretions. Now, with the implementation of universal precautions and increased awareness of infection control measures, the incidence of herpetic whitlow has decreased. Prior to the widespread adoption of the universal precaution and consistent use of examination gloves, the herpetic whitlow was primarily affecting the dental practitioners, especially those dental practitioners who had direct contact with the infected individuals. This infection now earned the term in dentists as wet-fingered dentist due to the nature of the transmission, often occurring due to the physical contact during dental procedures. For clinicians who were previously not exposed to herpes simplex virus, that is seronegative, a contact with the infected individual would lead to vesiculo-ulcerative eruptions on the fingers rather than the oral region. Symptoms of the primary systemic disease such as fever, malaise may accompany the finger lesions in seronegative individuals. Recurrent lesions, if they occur, are expected to appear on the fingers in case of herpetic whitlow. Herpetic whitlow, wherever it will come, it means herpes on the fingers. Although less likely, the herpetic whitlow can also occur on seropositive clinicians, those with a history of herpes simplex virus infection, but they are at a lower risk because they have the autoantibodies produced against the similar strains of herpes simplex virus during the previous infections or previous stimulation by the herpes simplex antigens. Now, herpetic whitlow is characterized by significant pain, redness, swelling, and affected fingers. Over time, the vesicles, fluid-filled blisters or pustules they develop, which eventually break open to form ulcers. Additionally, the lymph nodes in the armpit, axillary lymph nodes, or near the elbow, that is epitrochlear lymph nodes, they may become swollen and tender. The duration of the herpetic whitlow can be prolonged, lasting from 4 weeks up to 6 weeks from the onset to resolution. Microscopically, intraepithelial vesicles containing exudates, inflammatory cells, virus-infected epithelial cells, keratinocytes, they contain one or more homogeneous glassy nuclear inclusion bodies. What they contain? They contain glassy nuclear inclusion bodies on the cytologic preparation. The microscopic appearance of herpes simplex virus type 1 and type 2 are identical. Now, when the patient gets treated, then after several days, these herpes-infected keratinocytes, they are not present in the biopsy or cytologic preparations. So this shows that the person has healed from the infection. Next is differential diagnosis. The primary herpetic gingivostomatitis is usually apparent from its clinical features. It can be confirmed by the virus culture, which requires 2 to 4 days for positive identification. Immunological methods using monoclonal antibodies or in situ hybridization techniques have become usually successful for specific virus identification in tissue sections. Now, systemic signs and symptoms coupled with oral ulcers They may require differentiation from streptococcal pharyngitis, erythema multiforme, acute necrotizing ulcerative gingivitis, or Vincent's infection. So how will we differentiate a streptococcal pharyngitis? Clinically, the streptococcal pharyngitis do not involve the lips or perioral tissues, and vesicles do not proceed to ulcers in streptococcal pharyngitis. But in case of herpes, they do involve the lips, they do involve the perioral structures, and vesicles do proceed to ulcers. Next is oral ulcers of erythema multiforme can be differentiated from herpes simplex infection by the appearance, that is the erythema multiforme blisters are larger, usually without a vesicular stage, and are less likely to affect the gingiva. Next is ANUG, that is acute necrotizing ulcerative gingivitis. It also commonly affects the younger adults. However, the lesions in the ANUG are limited only to gingiva and they do not proceed by vesicles. And moreover, the considerable pain and oral malodor are constantly reported in ANUG. Now, secondary herpes is also confused with aphthous stomatitis, but it can be distinguished from it on the basis of clinical features. Multiple lesions, neurological prodromes, that is tingling sensation, vesicle preceding ulcers, and palatal and gingival locations are indicative of herpes simplex virus. This we need to keep in our mind. In contrast to herpetic lesions, the aphthe or the aphthous stomatitis are commonly found exclusively on non-keratinized mucosa, such as the floor of the mouth, in the alveolar mucosa, and in the buccal labial mucosa. So these were some examples of how we differentiate herpes simplex virus infection from other diseases. Next we have is diagnosis. Several techniques are available to confirm the diagnosis of a primary herpes simplex virus infection. First is Zank smear, serology test, viral culture, immunohistochemistry or polymerase chain reaction testing. Of note, the use of Zank smear on the preparation is helpful only if the person is positive. Then only Zank smear will test positive for the sample provided by the patient. Now next we are going to talk about the treatment. One of the important factors in the treatment of herpes simplex infection is timing. Medication should be initiated as soon as or as early as the prodromal symptoms are recognized to maximum effectiveness, so as to maximize the effectiveness of the therapy. Ideally, the therapeutic measures should commence or start within 48 to 72 hours. Several drugs specific to combating the virus have been developed for the treatment. Among them, acyclovir mostly used. It is commonly most prescribed medication for herpes simplex virus infection. Now, acyclovir and its analogs have demonstrated the significant efficacy in treating the mucocutaneous herpes simplex infections. First is that disrupt the viral replication, that is acyclovir and pancyclovir. And second is that prevent the interaction of virus and epithelial cell surface, that is docosanol. Acyclovir undergoes conversion by a viral enzyme called as thymidine kinase into its active form, that is acyclovir triphosphate, within the herpes infected cells. Now, acyclovir triphosphate competitively inhibits the viral DNA polymerase, which is essential for viral DNA synthesis without affecting the host cell DNA polymerase. This mechanism ultimately interrupts the viral DNA synthesis while preserving the cellular DNA synthesis, leading to the suppression of viral replication. Now, systemic antiviral medications such as acyclovir, that is 400 mg to be supplied 3 times a day, or valacyclovir, that is 1000 mg twice daily, are effective in managing the primary genital herpes infections. They also show some efficacy in controlling the primary oral herpetic gingivostomatitis, although to a lesser extent. Now, supportive therapy plays a crucial role in overall treatment regime for the primary herpetic simplex infections. Supportive measures include maintaining hydration, allowing adequate rest, performing oral rinses or oral lavage, and simultaneously administering pain relievers or analgesics and fever relievers or antipyretics. Combining the antiviral agents with the supportive therapy can help alleviate symptoms and promote faster recovery from the primary herpes simplex infections. Prophylactically, systemic acyclovir is particularly effective in the problematic cases and in the patients with weakened immune system. In severe cases of secondary herpes, among HIV positive patients, intravenous acyclovir or ganciclovir may be necessary. The use of topical acyclovir in the treatment for secondary or recurrent herpes is there, but the effectiveness is limited. Applying 5% acyclovir analog ointments 5 times a day at the onset of the symptoms may slightly reduce the duration of herpetic lesions and potentially prevent some of the lesions from fully developing. Another topical option, that is endocosanol 10%, has shown effectiveness. It is important to note that the topical management does not prevent the recurrence and may not be effective for all the patients. So this is all for the herpes simplex infections video. Thank you for watching.